Director General Dr. Nageshwar sir, Director Dr. C.V. Rao sir, Principal Dr. Bhimeshwar sir, all the senior and junior faculty and senior and junior residents for today's afternoon session of clinical case discussion of interesting cases. So that will be followed by academic framework guidelines for clinico-pathological conference by Dr. A. Venkateshwar Rao sir, Professor of Emergency Medicine. So first we have interesting cases discussion. We have two cases for discussion today. The first case, we have two cases for discussion. The first case, isolated renal and urinary tract aspergillosis from Department of Urology. The second case, multifocal hepatic hydatiditis from General Medicine. So first we'll start with the urology case, isolated renal and urinary tract aspergillosis presented by Dr. Sriram. Case will be moderated by Dr. Surya Kumari Madam.
Today I am going to discuss regarding an isolated renal aspergillosis case which we faced which was a diagnostic challenge for us. So the patient was a 32-year-old male, salesman by profession. So he presented in the Department of Urology with left loin pain, nausea, burning micturition, and some white cheesy materials in his urine and fevers. So the cheesy materials were kind of like this. This is the patient only took the photo and got us. So next, the history of present illness. The patient initially presented with left loin pain, which was colicky in nature and radiating to the left loin since 1 day. The patient was accompanied by the pain was accompanied by nausea, high-grade continuous fevers with chills and dryness. So the patient has two similar episodes 2 months and 4 months back, which were relieved with antibiotics. And the patient past history, the patient is known case of hypertension and diabetes mellitus. He also had a history of left staghorn calculus, for which he underwent left PCNL on the 14th of August 2025. So the patient also had a lower pole calculus on the right side during the same surgery. So for that, again he underwent bilateral RIRS for the remnant calculus on the left side and the calculus on the right side. So these are the CT images of the first surgery which the patient underwent. So here we can see left staghorn calculus and right side lower pole calculus. So this is the report. Here we have a 4 into 3 into 1 centimeter left renal pelvic calculus with mild prominence of the pelvic axial system. So this is the post-op CT image after we have performed the PCNL. This is the post-op image. We can see bilateral stents and remnant, small bits of remnant calculus in the left kidney. So on clinical examination, the patient was conscious, coherent, cooperative, and oriented, moderately built, well nourished, with a BMI of 28 kg per meter square and BP of 130/80 and pulse rate 96. Saturation was 98 on room air. Temperature at presentation was 101 degrees Fahrenheit. Respiratory rate was normal. So the respiratory system, bilateral normal vesicular breath sounds were heard, no added sounds. In the per abdomen was soft, mild tenderness was noted on the left loin region. There was no palpable mass and bowel sounds were normal. All quadrants were moving equally on respiration. So CNS, there were no focal neurological deficits and CVS S1, S2 were present. So these are the blood investigations of the patient. HB was 15, which was normal. PCV 47, counts were slightly elevated, and platelets were normal. Blood group being O positive. The serum creatinine was elevated. It was 2.2 milligrams per deciliter. HbA1c was also elevated. The patient is a known diabetic. The RBS presentation was 242. So in the complete urine examination, we can note there are proteins in the chemical examination. Blood and leukocytes are also noted. In microscopy, we could find 22 RBCs per high power field and WBCs 65 per high power field. We also sent a urine culture which came back as no bacterial growth.
In microscopy, you don't have any crystalluria having so big a calculus?
This was not during the first encounter, sir. The CUE I am displaying now is after the patient presented with the above mentioned complaints. This was the chest X-ray. My radiology colleague is gonna comment regarding
this. This is a frontal chest X-ray, whereas the trachea is in the midline and cardiac shadow appears to be within the normal limits. Bilateral lung fields appears to be clear and CPM is appear clear and both domes of diaphragm are well outlined.
So this is the ultrasound abdomen which we recently took of the patient. Here we can note that in the left side there is mild dilatation in the pelvic calcium system and the proximal ureter. This could be due to a calculus, but we are not sure what is the cause for the dilatation at the moment. So at this point of time we have arrived at the provisional diagnosis. It could be either as the patient had similar complaints previously after the removal of the calculus. So we got suspicious and these are the provisional diagnosis which we arrived at. One was recurrent pyelonephritis, or it could be renal papillary necrosis as the patient is a known diabetic patient, and it could also be a remnant calculus which is causing the above symptoms.
You still conclude and continue having the diagnosis of renal papillary necrosis after your ultrasound and urine examination? Entertain it or you don't entertain, or you will have hesitant to entertain?
Come again, sir, I couldn't get the question.
No. You have got your ultrasound examination.
Yes, sir.
And your urinary CUA complete. How far we can continue to entertain the diagnosis of renal papillary necrosis in this patient who are presented to you?
Mainly, I came with the provisional diagnosis of renal papillary necrosis because we could see CAS clearly complained by the patient, and we also have the CAS. We got the CAS and we sent them for the biopsy.
We had a solid excretory component.
Yes, sir. Could be. We cannot rule out renal papillary necrosis completely by the above mentioned investigations.
What's a CUE blood RBC?
Sir,
complete urine examination, what is the blood count?
it was around 22 per high power field, RBCs.
Told that.
Yeah, I did.
In favor of that rather than your white cast.
Yes, sir. So since patient had recurrent episodes of similar complaints, we have collected and sent the white mucus-like substance in the urine for histopathology. So we wanted to rule out any rare causes like fungal basols. So this was the one sent for histopathology, and my histopathology, my
size of it, because it is blown out of proportion.
It was around 4 into 2 centimeters, sir. So my pathology colleagues are going to comment regarding the slides.
These are representative histomicrographs submitted from the submitted tissue. Where in scanner view we can see necrotic tissue here. Along with that we can see inflammatory tissues, inflammatory cells. So in view of fungal elements, a special stain by name gomari-methimine silver has been performed, and here we can see fungal elements which are positive, and these fungal elements are focused under high power, where we can see septate hyphae which are branched, and this branching is acute angle branching, which are suggestive of aspergillosis.
When you are presenting the slide, the description by the pathologist or the microbiologist should be endorsed here, because he is given 4 points. Can you recount the points for the sake of audience?
So fungal elements are positive, which are septate hyphae. The hyphae are septate. The branching is acute angle, suggestive of aspergillus, sir.
This is the magnified image where we can see acute angle branching and dichromatous branching, which is specific for aspergillus. So, moving on to the histopathology report. So, in the microscopy, we could find necrotic debris, mixed inflammatory cells, predominantly composed of lymphocytes, few neutrophils, and branching fungal hyphae, with which we came to the conclusion of aspergillosis. So, after the histopathology, we initially reviewed the obstruction which was caused by the fungal bezoars, which were coming from the urine, by ureteroscopy and degestenting, and later we started him on antifungal regimen of tablet voriconazole 200 mg for 4 weeks. Right now he is still under the treatment, and after the treatment the severity and the intensity of the recurrent pyelonephritic episodes has decreased. So this is our final diagnosis. It is left renal aspergillosis with recurrent colic episodes and AKA with diabetes type 2 and hypertension. So, regarding the rarity of this disease was first described in 1891 in Germany. So, here. Sure.
Any specific study?
So actually in a fungal staining, actually LPCV mount we can do, sir. If this specimen is received to the microbiology department.
Any serological testing for aspergillus?
Serological test is there. Serological test also is there, sir. And also mostly this is aspergillus fumigatus is most common species, sir, in this renal aspergillus fumigatus, sir. And also what I...
One. The aspergillus fumigatus is a pathogenic organism or a commensal in and around the entire human things from proctodium to stomatodium to anywhere.
Yes, sir. Usually it is a commensal contaminant, sir. Actually lab contaminant, aspergillus niger and fumigatus. But this sample is from the renal tissue.
Yeah.
So it definitely... yes.
Yeah.
And the angioinvasion is also is there, sir. The spread of infection is maybe from the blood spread, immunogenous spread to the kidneys.
Now one question, Doctor. Is it a colonized aspergillus on a destroyed kidney by your lithotripsy, or is it really a hematogenous localization of so because it's diabetic? Simple question. When they are doing lithotripsy of the staghorn colliculus, you do it percutaneous or you do it urethral with stenting and all? My question. I do not know.
Both procedures are done, sir. Percutaneously,
There should
PCN
be some from urethra to stenting will be there.
through the skin also, sir. PCN.
Yeah.
Both procedures were.
Now, how do you say it is not a colonized component within that after staghorn colliculus?
There is no means of actually saying that for sure, sir, but
Because diabetes will have a colonization much faster than the rest of the individuals. Therefore, there is a necrotic material post
Procedure.
shock and lithotripsy.
Sir.
And then we have gone from subcutaneous as well as periurethral.
Yes.
It might have colonized rather than. Why? You answer everything. There is medicine is not Nandiswara. It is something with the horns. Right?
So no fever episodes or debris before surgery, sir. Started after surgery.
After surgery.
After surgery.
After removal of the staghorn canal.
Yes, sir. So we thought it could be contamination from the endoscope, sir. Instruments.
Therefore,
Instruments
aspergillus is focal component of contamination.
From
But the
sir.
fever is associated with pyelonephritis.
Those are because of obstruction, sir. Renal obstruction because
And
of
secondary.
and secondary bacteria.
But you have no organisms grown.
Culture was
Culture.
negative, sir. No organism. Every month he will come, sir. For the same complaint, he will pass that debris and he will get resolved. Repeated for 3 to 4
Why
months.
I am interested in this component is it a colonized one? There is a diabetes. 2 is a biplanar trauma. 3 is an obstruction. Prior, there is a destroyed renal pelvis tissue by staghorn colliculus. Further, last question. If there is a staghorn colliculus of that magnitude, what biochemical milieu is responsible for extra hepatic colonization unlike a normal individual? He is a diabetic, colonization is go. But he had another metabolic disease. Is it infection related staghorn or no metabolic component at all? That's the question. Have they analyzed the stone?
No, sir.
Staghorn is
We did not analyze the staghorn.
no, okay. What is staghorn? I should not ask this question. You must tell. Substance, chemical.
Calcium monohydrate.
There is no crystal without calcium in the world.
Phosphate.
Calcium phosphate.
Triphosphate, magnesium phosphate.
Why I am asking that? The moment ammonium is present, you want to comment, sir? Or you want the nephrologist to comment? Ammonia is an alkaline component or acidic, or ammonium is different, which can make the local environment conducive for bacteria, conducive fungus.
Ammonia per se is neutral. Ammonium is acidic, so that gets broken down by protease as much as staghorn, causing diarrhea.
Wonderful. Protease, yes.
Protease species.
Which can break ammonium to ammonia. Am I right, sir? And which can make wonders of all these things. Now, any further final comments before we go to the second case? Therefore, you cannot conclude unless, without suppose if there is no staghorn calculus and other things and intervention, if the aspergillus is present, it is a primary renal aspergilloma or aspergillosis and so on.
Especially this is a rare
Even
case,
that it is rare.
rare case,
Yeah.
but it is iatrogenic. But sometimes there be systemic component also.
Diabetics can have a systemic.
Diabetics and post-renal transplant.
That's why he has taken X-ray.
Hematogenic.
But X-ray doesn't rule. You would have taken CT of chest for you to present this case that there is no lung lesion. If there is a lung lesion, it becomes a primary. If there is no lung lesion, it becomes a constitutional local problem.
In HIV patients and immunocompromised patients also. But renal involvement is majority, that is 70% renal involvement is there. But prostate and last bladder is also there, but minimum amount.
Last question. If it is a primary aspergilloma of the kidney, not a vessel immunocompromised and other things all, you will have a huge amount of ultrasound findings as well as CT findings. Like that. Probably you have done this as an exercise, but not the primary.
Large echogenic masses will be present in ultrasound study.
Yes. Any more questions? Appreciate. Then we'll go to the second.
So, disease was first described in 1891 in Germany, and so with the help of the systematic review done by Baumgarten et al. So these are the findings of the meta-analysis. So there were only 91 cases which were published from like 76 articles, spanning nearly a century from 1925 to 2023, where the study was done. So here we identified a common pattern in this disease. So predominantly this disease affected male patients, which is almost 9 out of every 10 patients were male, and isolated infection was noted on one or both the kidneys, which is the most common presentation, 8 out of 10 cases. And patient usually had risk factors like diabetes mellitus, HIV infection, and certain cancers. So with the symptoms could be ranging from flank pain, passing blood in urine, passing fungal particles like bezoars in the urine, or pain while passing urine, and it could also last fevers. So the diagnostic method included histopathology, which is gold standard in this case, and other imaging techniques like CT and ultrasound.
You have used the word, beautiful word, bizarre. That means your diagnosis is only a colonizing component rather than a constitutional invasive component.
So the treatments vary from involving antifungal medications such as voriconazole and amphotericin B, which were usually used in a systemic infection. And we can also perform drainage of abscesses if any were noted. and surgical removal of the affected kidney was rarely done in some cases. And overall, this has a mortality of 1 in 4 affected patients. These were my references. Thank you.
Thank you. If there are no questions, we'll go to the second case.
Thank you. Now the second case, multifocal hepatic hydatid cyst from Department of General Medicine, presented by Dr. Sri Shrita. Case will be moderated by Dr. Surya Teja, Assistant Professor, General Medicine.
Today's topic of discussion is about multifocal hepatic hydatid cyst. I am Dr. Sri Shrita, second year postgraduate, Department of General Medicine. A 49-year-old male came to OPD with complaints of yellowish discoloration of eyes since 3 months, complaints of high color urine since 3 months, complaints of pain in right hypochondriac region since 3 months, complaints of fever since 4 days, complaints of cough since 3 days, complaints of sore throat since 3 days. Patient was in usual state of health 3 months back, came with complaints of yellowish discoloration of eyes since 3 months, no discoloration of skin, complaint of right hypochondriac pain, insidious in onset, dull aching and dragging type of pain, no aggravating or relieving factors, not associated with vomiting or loose stools. Complaints of high color urine on and off since 3 months, not associated with burning micturition, suprapubic pain, and no tenderness or no change in urinary frequency. Complaints of fever since 4 days, high grade, not associated with chills and rigor, not associated with myalgia, arthralgia, or no diurnal variation. Complaints of cough without sputum, no history of shortness of breath, chest pain, sweating or palpitation, no history of reeling sensation, lethargy, no history of flank pain, hematuria or renal colic, no history of new onset limb weakness or altered sensoria. Patient visited AIMS Mangalgiri 2 months ago for yellowish discoloration of eyes and pain in abdomen. USG abdomen was done, revealed multiple hepatic cysts with internal echoes, suggested contrast enhanced CT which revealed multiple hypodense lesions seen in both the lobes of liver, which could be multiple simple cyst or multiple cystic metastasis. Tumor markers were done, carcinoembryonic antigen and alpha fetoprotein were negative, advised for serology and fine needle aspiration cytology for parasitic infection or hepatocellular carcinoma. Hydatid serology and cysticercosis serology revealed negative for cysticercosis and positive for hydatid ELISA serology. FNAC revealed multiple refractile flower and fan-shaped structures, which could include Echinococcus granulosus. Past history of fall from by 2 years back, advice for conservative management. Patient is not a known case of hypertensive, diabetic, bronchial asthma, TB, cerebrovascular accident or CAD, CLD, CKD or epilepsy.
Previous slide. At this point, comments from the Dr. Teja, who is moderator. You would like to endorse the component of microscopic aspiration, having known that case as a hydatid cyst, and then leave it, or you do an aspiration and do something else. Comment on that, because this has come from a big institute.
So usually aspiration of an active cyst is not preferred because of anaphylaxis, or we ourselves giving the seedling to the peritoneal cavity. Otherwise, they could have injected
liver. Therefore, they do it from the independent part, not contaminating. Then you can do it.
We can give this colicidal agent as well, which
Therefore,
is not.
They have done it, but they have done half-hearted,
Yes.
but not full-hearted. Why I raising that question? The moment you diagnose, is it a calcific component and active component by ultrasound?
Sir, it is active.
What is the ultrasound grading of the cyst at that point of time with that picture? Go back to the ultrasound. Any comments from your side?
So usually and Jeffries usually?
Because there is a grading system which is followed by both radiologists as well as clinicians. Am I right?
Yes, sir.
WHO-C category.
Yes, yes.
It's an active stage.
Therefore, this it should be aspirated or not. If it is a calcified, you don't aspirate.
Yes.
But till there is no calcification, you aspirate it for the sake of confirmation. But at the same time, you have the bond and responsibility to kill the entire things. I think there are so many surgeons who their experience with the hydraulic cyst at this point of time. Any hydraulic cyst aspirated and done? Therefore, even if you do not know the diagnosis, but if you think that it is hydrated, you have the liberty to aspirate except for the general cavities, the solid organs, provided you kill that by simply giving. How do you give how much of anti-squalidal drugs?
So 20% of sodium chloride can be given, or
Therefore,
95%
super hypertonic saline.
Yes, sir.
But 20% is available in every pharmacy. What is the best way? You make a saturated solution and beyond and heat it until and then make it sterile and give it and dry it back. Because 25% is available provided you ask for it earlier. You cannot get it at the time of aspiration. You must prepare with it. Only to write that question. Therefore, the patient is lucky. He has not been contaminated. Where they have done, I do not know. From the intercostal space, from anterior space. If the anterior space, it is legally taken to task. And fortunately, it didn't go for any complications. Otherwise, you will go into catastrophic peritoneal seedling, which is a death penalty for him. He cannot do anything for it. Thank you. Next, go ahead.
He takes mixed diet, is also non-pork eater, normal sleep and appetite decrease since 2 months, normal bowel and bladder habits, known alcoholic and smoker since 20 years. No relevant family history. On general examination, patient is conscious, coherent and oriented, height 152 centimeters, weight 64 kgs and BMI is 27.7 kg per meter square. No pallor, icterus present, no cyanosis, clubbing, lymphadenopathy or edema. Vitals at the time of presentation were normal. Temperature revealed 100 degrees Fahrenheit. On parabdomen, soft right hypochondriac tenderness is present with no organomegaly. CVS normal S1, S2 heart. Normal vesicular breast lumps are present. Provisional diagnosis could be multiple hepatic hydrated cyst with chronic alcoholic and smoker.
Multiple is a plural, I think so. Am I right? What is lacking there?
Yes.
Huh?
Cyst. ECG shows normal sinus rhythm. CBP revealed mild anemia of 11.6 gram% with neutrophilic predominance with elevated ESR. Peripheral smear shows normocytic normochromic anemia with normal serum electrolytes and calcium. His RFTs and coagulation profile normal and total LFT shows conjugated hyperbilirubinemia with enzyme elevation, ALP 153, SGOT 133 and SGPT 55 with normal protein and serum albumin and globulin. CUE revealed bacteria with trace of protein and urobilinogen 1+. Treatment at the time of admission is IV fluids, tablet albendazole, injection pantoprazole, injection ondansetron and tablet ursodeoxycholic acid 300 mg BD.
How long you have given the albendazole?
6 months.
This is a frontal chest X-ray. Trachea is in midline. Cardiac shadow appears to be within normal limits. Bilateral lungs fields appears to be clear. CP angles are free, and both domes of diaphragm are well outlined. And there are old heel fractures noted involving 5th, 6th, 7th, and 8th ribs on right side, and also a mid shaft of the clavicle.
Ribs are fractured anterior or posterior component?
Posterior, sir.
Ultrasound abdomen and pelvis revealed borderline hepatomegaly with multiple cysts, with few of them showing internal echoes in both the lobes of liver. Could be hepatic cyst or hydatid cyst. Grade 1 fatty liver with cholelithiasis.
It's an axial section of CT showing prominent sulcus spaces and ventricular system. So no other interaction or extraction masses seen. Normal.
Vitals are stable at the day 1 of presentation with continuing of same treatment, tablet albendazole. Gastroenterology opinion was taken, advised to continue albendazole for 6 months and review with LFT reports after 1 week. Patient was continued with same treatment and stable vitals from day 2 to day 4, and urine culture shows no bacterial growth. 2D echo revealed no dysfunction, good normal LV function with good LV systolic function. Grade 1 left ventricular diastolic dysfunction with normal IVC, no PE clot or vegetation. Serial CBPs from day 1 to day 5. There is mild decrease in hemoglobin and ESR shows elevation. LFTs pattern from day 1 to day 6. Conjugated hyperbilirubinemia with transaminitis. With cholestatic pattern and alkaline phosphatase elevation. Serial CUV shows normal. There is no bacteria by the time of day 5. Final diagnosis could be multiple hepatic hydatid cyst with chronic alcoholic and smoker.
Why are a persistent elevation for the last 1 month of your time of alkaline phosphatase in this case?
Could be due to compression from the cyst.
SGOT was high, Amma.
Is an yes, sir.
So it was alcoholic hepatitis rather than hydatid cyst causing the liver disease.
Maybe due to alcohol.
Because all the things show high SGOT compared to SGP, right?
Yes,
SGP is just borderline.
Yes, sir. He did not stop alcohol, sir. Yes, sir. Yes, sir.
Nowadays,
Because there is a rise of SCPT lesser and SCOT 2 times. Dr. Warren Professor proposes that can be an alcoholic hepatitis. You agree to it? But what happened to alkaline phosphatase persistently?
Maybe due to cyst compression alcohol.
It also rises alkaline. Any comments from your side?
First day picture is explanatory for alcoholic hepatitis things. But
Yeah. My question simple. Is it a multiple cyst causing obstructive component and irritative component? An obstructive component need not be there, but in any irritation intrahepatic alkaline phosphatase rises, irrespective of space occupying irritative relation in the liver. Need not compression, there need not be any biliary dilatation. And then SCOT will rise because you had an inflammatory condition. SCOT is ubiquitous enzyme everywhere in the body, starting from the kidneys to anywhere. He is a diabetic. Therefore, the bilirubin rise and other things, you can suspect alcoholic hepatitis, but persistent elevation of alkaline phosphatase, but the other things are not coming. It is not coming now. Think it's that.
AJ reversal. Why did you develop AJ reversal? Albumin globulin reversal.
Oh, wonderful question. Albumin globulin is almost equivalent. Therefore, there is no alcoholic pathology of the liver. Liver is going well. Comments? Any parasitic chronic diseases of this nature will have hyperglobulinemia, secondary little. And you should correlate with your associated eosinophilic component in the CBP. I do not know what is the eosinophilic component. Then we have to go to the second presentation. 66664. That's all. Total. Now this case is readmitted after how many months?
1 year.
1 year. Wonderful. Your treatment of 6 months is over. Now second presentation. Fast. Because we have to finish in another 10 minutes.
Good evening to everyone.
Oh, a lot of time.
V. Joshni, second year postgraduate, presenting the second part of the case. 49-year-old man presented with chief complaint of fever since 3 days, chief complaint of abdominal pain since 3 days, decreased urine output since 3 days, vomiting since 2 days. Patient was in usual state of health 3 days back, presented with chief complaint of fever since 3 days, which are high grade, associated with chills and rigors, associated with myalgias, no arthralgias and no diurnal variations. Chief complaint of decreased urine output since 3 days, associated with burning micturition. Chief complaint of abdominal pain in right hypochondrium, epigastrium, both loin region since 3 days. Dull pain which is insidious in onset, gradually progressive, not radiating to any site, no activating or relieving factors. Chief complaint of vomiting since 2 days, 2 episodes per day, watery, associated with food particles, non-bilious, non-projectile. No history of shortness of breath, chest pain, palpitations, cough or loose stools. Past history is a known case of multiple hydatid cysts in liver since 1 year and used albendazole for 6 months. Not a known case of hypertension, type 2 DM, bronchial asthma, TB, CVS, CAD, CKD or epilepsy. Personal history, he takes mixed diet, is a hope eater, a normal sleep, decreased appetite since 3 days, known ex-alcoholic since 20, and he used to take alcohol since 20 years, stopped since 1 year, and ex-smoker, stopped since 1 year. Vitals at the time of presentation, BP was 130/80, pulse rate showed 112, which is mild tachycardia, and SpO2 is 98%. DRBS at presentation is 290 milligram per deciliter. General examination, no palar, icterus, clubbing, cyanosis, lymphadenopathy or edema is present. Patient is conscious and coherent. Systemic examination, shape of abdomen is globular. Parabdomen showed soft, tender in right hypochondrium, epigastrium, left hypochondrium, bilateral lumbar region, no guarding or rigidity, bilateral renal angle tenderness is present. Rest of the systemic examination is normal. Provisional diagnosis, complicated UTA, a suspicion of pyelonephritis. ECG, this is standard 12 leads ECG showed sinus tachycardia, chest X-ray.
This is a frontal chest X-ray. This is a mid-inspiratory film. Trachea is in midline. Bilateral lung fields appears clear to the visualized extent. CP angles are clear and both domes of diaphragm are well outlined. As described in the previous X-ray, the old heel fractures noted involving the right side ribs and clavicle.
Go back to the slide. Any comments on this? These 2 lines?
As it is a mid-inspiratory film, sir, it may be due to...
Oh, expiratory and inspiratory, nothing new comes, it is as good as that is saying. There are 2 present lines which are oblique 1 and parapetal, which is a high intensity component. They are all fibrotic stacks. Either they may have gone for the liver aspiration of the 1 year and the tract might have been through the lung or otherwise, which is not present in the first film. Okay.
CVP at admission showed thrombocytopenia of 18,000. Total leukocytes were normal. ESR was elevated at 88. RFT showed urea of 208 and creat of 7. Serum electrolytes showed hyponatremia. Sodium is 117. HbA1c was elevated at 10.1. TSH is normal 3.3. LFT at the presentation showed total bilirubin of 2, which is in direct pattern. ALP is 118. Rest of the enzymes are normal. BT-INR was normal. The fever profile showed negative and virals were negative. CU at the time of admission, protein showed 2+, glucose showed 3+, leukocytes were 3+, and WBC showed plenty. And serum osmolality at the time of presentation was 300. Spot urine osmolality is 253. Uric acid is elevated 11.7. Phosphate was normal 3.4. Amylase lipase were normal. Lipid profile showed triglycerides mildly elevated 357 and blood ketones were negative. ABG at the time of admission showed pH of 7.3, bicarb of 16.8 and PCO2 of 29.8. Anion gap was 10.2, which is a normal anion gap metabolic acidosis with respiratory compensation. Treatment at the time of admission: 1 IV fluids, 1 pin Taril and 1 pin at NS at the rate 100 ml per hour. Injection piperacillin and tazobactam 0.25 gram IV 8th hourly. Injection doxycycline 100 mg IV 12th hourly. Injection Panta 40 mg IV 4th hourly. Injection ondansetron 4 mg IV SOS. DAP Sodacil per oral 12th hourly. TAP for Rixostat for 40 mg per oral 24th hourly. TAP Shilcal 500 mg per oral 24th hourly. Actrapid was given at 22 units and 16 units, started according to GRBS. And liver showed well-defined heterogeneous iso to hypoechoic lesions noted in the both lobes of the liver with a thin peripheral hyperechoic rim. The largest lesion measuring 3.1 into 2.6 centimeters in the right lobe. There is no intrahepatic biliary radical dilatation or CVD, PV and inferior vena cava is normal. Impression: cholelithiasis, hepatomegaly with grade 1 fatty changes, few well-defined heterogeneous iso to hypoechoic lesions seen in both lobes of liver with evidence of thin peripheral hyperechoic as described above and possible hydrated cysts. PDs could be a neoplastic etiology. Splenomegaly, both kidneys appear enlarged in size and showed altered echo pattern as described possible infective etiology. Minimal right pleural effusion. CD.
This is an axial section of CT plain abdomen showing well-defined hypodense lesions in the liver. There are also hyperdense foci in the gallbladder lumen, the cholelithiasis, and the right kidney was bulky and is altered in echo pattern. Next. So the similar lesions were seen in the liver in the upper sections. Next. The bilateral kidneys are bulky with bulky cortex and altered echo pattern, like pyelonephritis changes with perinephric fat standing and the thickening of the fascia, lateral column fascia.
Tachycardia during study, no RWMA, mild concentric LVH, good LV function, EF 60%, grade 1 LVDT, mild MR, no AR, mild TR, PH, RVSP is 26 mmHg, no PE clot vegetation, IVC 0.9 centimeters and collapse. Nephro opinion was taken, aka grade 3, advised fluid restriction of 1.5 liters and planned for RRT worsening of RFTs. Day 2 to 3 of admission, vitals was stable. Patient had a fever spike of 101 Fahrenheit. Input output is 1500 by 1155 and GRBS is 140 milligram per deciliter. Treatment fluid restriction less than 1.5 liters. Rest of the treatment was continued. Day 2 of CVP showed mild elevated total counts, which is of 11,000 to 13,000. Platelets were 80,000. ESR was elevated 87 to 72.
At this point, I got a question. I like our nephrology faculty to clarify. Creatinine is mounting to 8 milligrams, urea about 300 mark, but still sodium is 122 and potassium. There is no mounting increase in the electrolyte in spite of the renal dysfunction. I would like to have a little amount of clarification from young or senior nephrology faculty at this point of time. Mike? Akkada? Nachara? Lati Biku? Question is, it is a huge amount of price of urea and creatinine amounting to a end-stage component, complete and impure. But the sodium and the potassium was very leaky with the output of normal. What is your expressivity with reference to the functionality?
Maybe because of the interstitial and tubular component. It may be due to the acute interstitial nephritis where there is there is
Therefore,
no
it's primarily a
component.
tubular dysfunction rather than acute and chronic or a chronic glomerular component. because that means, how do you confirm that it is our faculty of nephrology said that it's probably a tubular dysfunction. At the bedside, how do you confirm the tubular dysfunction? Because it is very good for us also, because there won't be anything retained in the circulation except for the urea to be. How do you confirm it? Would you like to advise anything to confirmation of tubular
There are
dysfunction?
few tests to differentiate
Only one
between
test I don't like to, we are a poor country.
urinary sodium excretion.
Yeah, spot urinary sodium should have been done to know what is the quantum of tubular dysfunction plotted on the x-axis of time frame. That will decide whether he has to undergo. At this point of time, we like to advise dialysis for this patient. When his vitals are good, temperature is good, and electrolytes are not disturbingly arrhythmiogenic or cardiac incompatible. We like to have a dialysis for this patient or not.
If the vitals are stable and
No, my question is simple. No question of yes or no. That's all.
currently no, sir.
Yeah, very good. Go ahead.
Blood culture and urine cultures were negative. Sodium was 122 on day 2 and day 3. Urea was 236, day 3 266. Creat was 7.4 to 7.9. Day 4 to 5. Patient vitals are stable. Input output is 2500 by 1300. GRBS is 179. Treatment fluid was restricted to 2.5 liters. Nephropinion was taken in view of elevated creat and advised RRT. One hemodialysis session was done on day 4. Rest of the treatment was continued.
Yes.
Serum CBP counts were elevated 16,000 to 17,000.
You tell only what was abnormal. Don't make next make the expectation.
Creat was decreased after post-dialysis session. It is decreased from 8.1 to 6.2. Sodium was 128. D-dimer is 1, which is mild elevated. LFT from initiation, there is mild elevation of LFT on day 3, which is in direct pattern, and enzymes were normal. Day 6 to 10.
There is not much change in the treatment at point except that he is not hypertensive at all. As a resident, you must note that non-hypertensive with a good amount of urinary output, a primary tubular damage. Therefore, you can give him as much fluid as possible to compensate in the absence of bad heart. Go ahead, faster.
Day 6 to day 10, vitals were stable, fluids are 2 liters, rest of the treatment was continued. CBP, there is elevated counts of 20,000 to 19,000. They are in the decreasing trend, reached till 40,000.
There is an improvement in the infective component. Next, please.
RFTs have improved. Creat has decreased from 6.2 to 3.8.
The journey of creatinine tells you what at this point of time as a resident from day 4 to day 10.
It is
with one single dialysis.
Reversible tubular.
Therefore, the dialysis is responsible for her journey of safe, or no dialysis is also responsible for it. Simple question.
No dialysis also is responsible.
Therefore, you learned how to do dialysis, but dialysis doesn't change that. It is changed on its own of normalcy. Thank you. Next, please.
Sodium was normal. LFTs at the time of discharge were normal. Procal at admission was.
It is decreasing.
It isn't.
Next.
Final sepsis secondary to pyelonephritis, aka grade 3, acute interstitial nephritis, known case of multiple hydatitis and de novo diabetes.
Wonderful. You corrected, yes. Huh? Anything, comments? This patient presented with 2 different catastrophic illnesses. One is a tropical disease of multiple hydatitis for which he received a good treatment for, and nothing happened. After 1 year he came back because he is a diabetic with complicated UTI, probably a right pyelonephritis, with a tubular damage of immense nature, which recovered fortunately because of your energetic treatment as well as his control of diabetes and so forth. Probably you must advise not to come back by a good amount of anti-diabetic medications and other things and support as a resident. Thank you. Any questions? No questions, we'll go. Any comments? It is an acute kidney injury. As a resident, you mentioned tubular and confirmed it by spot sodium which is equivalent to more than 50% of the serum sodium. Am I wrong, sir? Absolutely correct. Thank you. Episodes from 2 different units as a single individual. Challenge.